Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Suresti Health. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, CEO of Suresti Health, Dirk Sungson.
Hi, everybody. Thanks so much for taking the time to join. My name is Dirk Sungson. I'm one of the co-founders and the CEO of Suresti Health. I'm very excited about this discussion on kind of how to think about patients with dementia, how to keep them out of the hospital, kind of approaches for what we think are good practices and also with a focus on some outcomes. Before I dive in, I'd love for the panelists to each introduce themselves. So Cheryl, maybe we'll start with you, then go to Bart, and then go to John.
Oh, thank you so much, Dirk, and delighted to be here. Yes, I'm Cheryl Phillips. I'm a geriatric physician. My background is actually very varied. Physician leadership in multi-specialty medical groups, healthcare systems. My clinical passion was always post-acute and long-term care. And most recently, I was the president and CEO of the Special Needs Plan Alliance, a subset of Medicare Advantage plans targeting those high-risk, high-needs older adults. And right now, I am a consultant for the John A. Hartford Foundation. Thank you. How about you, John?
Bart.
Oh, Bart, let's go with Bart.
I'm Bart Asner, happy to be here as well. I'm a primary care physician, served 25 plus years as CEO of Monarch Healthcare, an IPA medical group in Southern California. Also worked as an executive for Optum with medical groups that were bearing risk all across the country.
Hey, and I'm John Mock. Thanks, Dirk and everyone. I'm a geriatrician internist. I spent 10 years at the Minneapolis VA in their multidisciplinary dementia clinic, where we had virtually every discipline you can imagine working with people with dementia and their caregivers. I then spent 30 years plus years working on population health strategies and programs for people with very high needs and high risk. I did that in a variety of settings, health plans for a large part of that, as well as provider health systems and home care companies. And lastly, I'd say that I'm the chair of the board of trustees of the John A. Hartford Foundation.
Terrific.
Back to you, Dirk.
Great. And I'm sure you could all recognize all of us from the caricatures that were on the invite. I think we all get a chuckle out of that. So the way we're going to structure today's session is I'll take about 8 minutes and kind of present 6 slides, which are kind of meant as context for the conversation. I'm hoping some of what I will show will be new and maybe provocative, and then we'll dive in to kind of unpack this and more. As already mentioned, please put any questions in the Q&A. They will either be answered immediately, we've got somebody doing that, or we'll keep them for the end. If we can't, we'll follow up afterwards. There will be a recording, so the slides will be available. There are clickable links in the slides. So if you say, well, where's that study? Where's this coming from? All of that's available. So with that, let me dive in, share my screen, and got my timer on, no more than 8 minutes to kind of walk you through some things about dementia. So first of all, we know that dementia is a growing national health priority. So what you see here on the plot is that of the 60 or so million people over the age of 65, more or less today, we'll have close to 80 million people who will be over the age of 65 in the US by 2040. The number of people with dementia will increase from 6.5% to 11.6 million. So that's, a big increase. The prevalence at that point will be about 14%. It's a very expensive condition. The average patient costs close to $30,000 a year. And it's really driven by, high rates of avoidable hospitalizations, fragmented care. You can read some of these things, right? It's a huge burden. It's a family disease. It impacts a person with dementia as well as their family and their caregivers. So when you think about patients in dementia patients in a Medicare population, the reference here is a Milliman white paper that details the cost and utilization of dementia and actually in a Medicare Advantage population. The key things here to realize is that individuals with dementia are not usually prioritized because historically there haven't been any effective solutions to improve their care. There are no medications that really work and so forth. The other thing we'll unpack today is that the impact that these patients have is often invisible from a cost perspective. And there's a couple of things happening. There's a masking of symptoms, and there's sort of ways that claims data is analyzed that make it hard to see the true impact of dementia. We will dive into this in the webinar. One of the key drivers for the poor outcomes of people with dementia is that they can't self-manage. This makes it difficult for them to engage in traditional clinical programs. The costs are actually not driven by the dementia per se, but really by unmanaged chronic conditions, by unmanaged infections and falls. This is why 42% of people who have dementia have more than 5 chronic conditions. Family caregivers can have a huge impact. They can help, but payers and providers don't really have the capabilities to engage caregivers effectively, right? So that's the gap. We'll talk about some of that. If you look on the right-hand side, people with dementia drive 21% of the total cost of care, 27% of all inpatient admissions. You can read some of the other numbers, right? But it's really significant. And looking at those numbers, you'd say that's a pretty important problem. If you look at this in a different study, this is a study that summarizes a 5% CMS sample in fee-for-service. If you bring all the people with dementia, so the purple bar is all the folks that have a dementia diagnosis, and we just assimilated all their costs. And you can see in this data set, which is a CMS 5% sample, dementia is the second most costly condition. For many of you, that's got to be a surprise, and we will sort of talk about why that is a surprise. And however, it is true, right? So you can look at this study, you can look at the enablement study, and you'll see that dementia is really, really expensive. And effective solutions now exist. The CMS guide model actually establishes a standard for dementia care. As you'll hear in this webinar, we think if you're going to set up a specialized clinical program for people with dementia, you need to think about what do you do with a caregiver? Can you enable them? We'll talk about the importance of detecting changes in condition, teaching the caregiver how to engage the healthcare system, supporting the caregiver, and of course, reducing harm, preventing falls, making sure that medications are reconciled and so forth. So the guide model, which we will touch on briefly towards the end of the session, is a new CMS model, an 8-year model, which was really aimed at improving outcomes for people with dementia. So CMS recognizes this is a really important problem. This is why they established the guide model. It requires that the family caregiver be included in the care team. It's a big deal. It pays a monthly care management fee, right, based on the stage of the person with dementia and the caregiver burden. There's an annual respite benefit. Any eligible traditional Medicare patient can align with the guide provider, and Medicare Advantage plans are not eligible, but we'll talk about what Medicare Advantage plans could do around dementia as part of this session as well. Just a little bit of background on who we are at Seresti. This will probably be the only slide that talks about kind of what Seresti does. Is we are a dementia care provider. We've been doing this for 7 or 8 years. We have a differentiated, low-cost model of care that delivers significant cost savings. The caregiver enablement piece is sort of our sweet spot. We can detect a change in condition in the home. You'll learn why that's important to keep people out of the hospital. It's a tech-enabled model. There's a turnkey solution that we offer, and we have clinical studies with independently validated cost savings. We're deployed in Medicare Advantage, and with a guide model, we're targeting accountable care organizations who are interested in unlocking cost savings. And just to sort of highlight what's out there in terms of dementia care studies, there are 2 studies that we're aware of that show high cost savings. One is a study that was published in JAMA Network by the University of California in San Francisco, their care ecosystem. This was a randomized controlled study. They reported annual savings of $3,212 per patient per year. And then you have the Seresti study, which was independently validated by the Validation Institute. The cost savings were slightly higher, $6,828 per patient. This was a propensity match In Medicare Advantage, the UCSF study was in fee-for-service. So you have a couple of data points that highlight the opportunity for cost savings in both traditional Medicare and fee-for-service patients. So that's my last slide. I actually beat my allocated time. There are links in all these slides that you are more than welcome to click on, right? The studies and so forth. So what I'd like to do now is start the discussion off with a question. And so the first question I'm going to ask Cheryl to maybe start with. It's, okay, I've said dementia is really expensive. It's the second most expensive condition. So what's your reaction to that? And is that typically something you've seen? And Cheryl will kick us off, and then we'll have other folks sort of opining on, like, this is probably a surprise finding. So Cheryl, please sort of kick us off here with that question.
So I think any of us on the audience knows that the prevalence of dementing illnesses is widespread. But if you look at medical records, or you look at claims, or you look at case finding for case managers or utilization review, very rarely does it pop up for a number of reasons. Usually those conditions that trigger better risk adjustment payment come up to the top. Many fields for claims are limited to 3. I think now most are expanding to 5 or 6, but often Alzheimer's or related dementia just didn't make it to the top. And so I think that many times health plans saw this as sort of a silent problem. I'll add the second problem that health plans saw was that they don't have any solutions. To them, the solutions for individuals with dementing illnesses was all social support needs. That was outside of the Medicare plan covered benefits. So, we'll let the social workers work on it. That's stuff that Alzheimer's Association and other support groups can take care of. And we're focusing on the medical diagnoses. So it's not that the health plans chose to be blind to dementia. They felt like they were pretty limited with what their options were for interventions. And I think we'll talk more about opportunities with care management, but we know it's prevalent. We know that primary care and specialty physicians see it all the time. They often don't chart it. They often don't open up that challenging can of worms because they're not really sure what to do. And so people continue to focus on the diagnoses at hand, the heart failure, the osteoporosis, the hypertension, the diabetes.
Dirk, perhaps I can speak on behalf of medical groups. So at Monarch Healthcare, we were actually one of the pioneer ACOs, one of the first ACOs in the country. And so we knew how to manage patients in that regard. But perhaps more importantly, we took global risk on our senior population and had many, many thousands of seniors to care for. As CEO, I certainly would always ask, where can we impact healthcare costs? And the care management teams we had, who were very good, and the data that we had, which was excellent, would always come up with the standard COPD and CHF and kidney disease, the usual suspects. In all the years I was involved, I never heard anyone bring up dementia. And I think we really did not understand how dementia was masking so many of these other diseases, these comorbidities, and the potential cost. Today, we're really all pretty good at managing the major illnesses, and we're looking for other ways to reduce costs. And dementia is a huge opportunity that, frankly, I was very surprised to find out about when I saw your data.
Terrific. What about you, John?
Yeah, I'm with both Bart and Cheryl. I don't recall, after years and years of looking for opportunities, seeing dementia on any sort of list. But I want to go back, Dirk, to one of the key points you made, is that it's really probably the multiplicity of conditions. And you cited some information that people with dementia have a lot of chronic conditions. I think many years ago, as you look at predictive modeling about who you can impact and the association between multiple chronic conditions and avoidable hospitalizations really got our attention. I think dementia is yet another special category, even beyond the multiplicity of conditions, because of the masking effect you alluded to. People with dementia don't have the normal response. for urinary tract infection or medication. It may not even raise concern because their response may be minimal, may be blunted in many ways. Therefore, these things, the problems percolate for several days. And then by the time you end up in the emergency room with low blood pressure or really people that have really markedly diminished mentation, it's probably too late. You can't do anything about it in the emergency room. Having said that, if you had some mechanism to understand what was going on 2 to 3 days ahead of time, then a lot of these are, what you would consider avoidable by standard definitions.
And I would add, John, that one of the problems that we always face is what are we going to do, even if we knew that we had dementia patients that were costing us a lot of money? Interacting with a dementia patient is not going to work. Interacting with caregivers who are not engaged and educated is really, really difficult. So I think even when people started to think about perhaps this is an area we can impact, it's really, really hard.
Cheryl, maybe I can turn this back to you, but we sort of talked about the plan. You said, look, the fact that there maybe aren't solutions and maybe it's a social problem is a reason why it hasn't been focused on. But what's the perception of a typical physician to working with somebody with dementia? Bart sort of alluded to it, but how does a PCP think about a patient with dementia?
Having been involved in also resident physician education, there's a lot of energy in the medical model of dementia. So most primary care physicians can list the various types of dementia. They can give you a differential diagnosis of dementing presentations. What they're typically not gifted with is the resources and knowledge of what to do in the broader platform. If you have a 7-minute appointment and it takes 5 minutes to get the individual into your room, and at the end of 3 or 4 chief complaints, the daughter says, and oh, mom's forgetting a lot of things, the primary care physician can give you a clinical diagnosis maybe, but then if they do that, it's like, then what? So let's again focus on the things that John was talking about where you feel like you have some short-term impact. And in part because we've looked at dementia, Alzheimer's and related dementias as a medical diagnosis, and it is the pure intersection of medical, functional, and social support that's often missed in the context of a primary care physician office. Not as fault to the primary care team, they're just not the best resource to help do that integration.
And at health plans and in medical groups that are fairly sophisticated, we have care management teams that can focus on this, but we have limited resources as well. And is there a point of focusing on dementia? Well, historically, there really wasn't a good case to be made for spending the time, as you've alluded to, with the dementia patients. When I saw the costs that Dirk showed, it opened my eyes to perhaps this needs to be rethought of in a different way.
Yeah, if I can add, and excuse me for jumping back in, but talking about care management, we've had care management resources around on the health plans and even in many integrated groups that have payment risk for decades now, but they were typically disease focused. They were most often one way. So the care manager called you really whether you needed care management or not at that particular time. They were often in isolation to the primary care team. And I used to use the term polymanagement syndrome because you'd have your diabetic care manager, you might have your heart failure care manager. The health plan has their utilization care manager, and all of these satellites are rotating around, often not in concurrence with the primary care physician or with the family caregiver. And so we found that care management, just the way we were doing it, even if we identified individuals with a dementing illness, it wasn't terribly helpful because we had the wrong strategy.
Right.
That's well said, Cheryl. So the strategies you have to develop for people with multiple chronic conditions are very different than single disease. I would think that it's actually with dementia, it's yet another frame shift because of the role of the caregiver in this instance and the role of social determinants. 10 years in a dementia clinic that was really richly staffed. We had a psychiatrist, an internist, a neurologist, a neuropsychologist, a pharmacist, physical therapist, occupational therapist. The one person that really mattered over the long term. So we obviously collaborated a lot on the initial diagnosis and initial treatment plan and screening for things like thyroid disease, et cetera. But longitudinally, what really matters is that relationship. And in our case, it was a nurse who carried the day on a longitudinal relationship with the caregiver about training, understanding, kind of heads up on what to expect on the next stage and what to do if. And that I think correlates nicely with what Dirk has mentioned on the caregiver side.
So, John, how did the nurses interact with the patients and the caregivers? I assume in that case they weren't engaged caregivers.
Yeah, they were. I mean, they're caregivers coming into the clinic with their loved one. So, we would separately meet with the caregiver typically. So if I was examining the patient, the nurse would sit with the caregiver to get more information. Sometimes you need that distance a little bit to get the full picture, build a relationship with the caregiver, and then, gave her her phone number and had a longitudinal conversation about over time. Here's where your loved one is staged today. Here's what you might expect in the next stage. You might be thinking about these three things. You can't overwhelm them, right? So you have to kind of piecemeal and tune it just in time information for them. And that was a skill that didn't really appear in medical school. It was really that nurse or social worker who was taking that on.
And that needs
to jump in here, Bart,
relationship,
if you don't mind. So I'd like to move to the next question, which is, trying to unpack what are the drivers of costs. So we've sort of learned, surprisingly, it's actually really expensive. So maybe, John, we can start with you since you have this experience at the dementia clinic. What are the drivers of costs for somebody with dementia? What are the biggest drivers?
Well, I mean, I think we alluded to this. It's really, you mentioned falls, infection, medication issues, exacerbations of underlying chronic disease. Those are the drivers. So when they show up in the emergency room, when they do get hospitalized, those were the diagnoses related. It's not the dementia per se. Now, that doesn't say it doesn't happen once in a while. Certainly, there are some behaviors within dementia that can cause problems in the hospital. Sometimes is the only recourse to that. But more often, it's these, what I think of as preventable things. And then unfortunately, once they get hospitalized, people with dementia, don't do well in the hospital. It's not a good place for people with dementia. It's a new setting for them, which is a big disruptor for them. They often get sedated. They're agitated. Hopefully, we're not doing restraints anymore. But they can get they have this cycle. They stop eating. Then they're not being fed, and then sometimes they get a tube feeding, and then sometimes they get aspiration pneumonia, and you get this vicious cycle, and they go home or back to their facility, and they actually have this step down in function that never recovers. And so then they're more costly the next time. So who's ever paying for the bed or for the home or all the out-of-pocket expenses for the family just keeps getting worse and worse. So breaking that cycle is really important.
If I can add, and Rajiv in the chat raised an interesting comment, because as we think about costs and understanding in this context, we're looking at the medical costs, the health plans, the medical groups at risk, but there is a much bigger global cost into the care of individuals with dementia that John made reference to, because the informal caregivers, the families, the interested partners that are doing most of this work, they're often not only expending their own resources, but they also are at a loss of where to go and what to do. And being involved in a number of outreach groups for family caregivers, their greatest stress, yes, it's costly, yes, they're missing work, but they also don't know what to do. They don't know where to turn, and they reach out to usual resources that don't respond back and give them the help that they need. So I think that this cost cycle starts to drive and starts to play out in so many ways. So when you're frustrated and dad is acting up and he seems more confused, you take him to the emergency room, and almost always, and no, I'm not dissing anybody in the emergency room, but you can usually find someone who's dehydrated with a UTI. So they get admitted, and then the cycle starts all over again. So it's an interplay of costs for both the medical system and the individual and their family unit and caregiver.
So what we really are talking about is reducing ER visits and reducing hospitalizations through the focus that this conversation is about, and that is working with the caregivers.
And Cheryl alluded to caregiver health as well, caregiver burden. And there's a chat comment that's really important here, is that caregivers for people with dementia also suffer and their health deteriorates. So it's as Cheryl and Bart have said, it's really a large picture here of an impact.
So given that we've said, okay, dementia is more expensive than most people recognize, the cost of dementia from a plan or payer perspective, if you're at risk, are largely around hospitalizations. So, John, I'll go back to you. How do you keep people out of the hospital? What can you do for people with dementia and their families to keep them out of the hospital?
Well, my favorite thing to do, if you have the opportunity, is, and excuse the phrase, but put an early warning system in place. So, well, maybe even before that. So engaging the caregivers I mentioned, educating the caregiver and other family members or anybody who's stopping at the home or even the facility about signs and symptoms in people with dementia that are different than people with, say, no cognitive impairment but have a urinary tract infection. So if, as I think I mentioned to Dirk once, I'll never forget this person in the nursing home who was standing on her bed clutching her purse, and it was agitated. And, the instinct of at the time, the facility was to send her to the hospital for, dementia behavior issues. But if you understood people with dementia and the risks around infection, you might say, well, let's just pause for a minute. Let's get a urinary tract, urine analysis. Let's start her empirically on an antibiotic. And sure enough, 24 hours later, she was fine. And, the alternative is to go to the hospital, as Cheryl was saying, and all the bad things that happen there. So catching things early and knowing what to do about it. And again, this is where the caregiver is so important, because the caregiver is just sitting there 24/7 and knows the difference between baseline and non-baseline things. And then with some help and education and training can distinguish when to make it act and then how to act if that situation happens. So that's probably the the training and education, the early warning system, and then figuring out what to do once you get an alert.
Well, and John, I want to just maybe modify something that you were referencing, because I totally agree with the early warning systems. And there was something that came up in the chat. We also have a problem with overdiagnosis of UTI in older adults, where 30% of older adults, particularly women, have asymptomatic bacteriuria. So somebody presents with a new confusion and we just assume it's the UTI and we give them antibiotics. I think part of the question is also having a care team that can start to differentiate underlying cognitive and dementia from new onset delirium, which may be medication related or multi-factor related, so that we start to have a more sophisticated care team. I think what we're saying throughout all of this is dementia is a serious clinical presentation. It's costly, it's often ignored, it's often masked by other acute presentations, which in fact the dementing illness is making worse. And yet we focus on the others and we miss the underlying dementia. And we miss it upstream when we can help with the family and the caregiver unit prior to it being the crisis that you talked about, John. So I was agreeing with everything. I just didn't want people to go away to think that if we gave everybody antibiotics, we'd take care of the problem.
No, that's right. That's right. And certainly, you have to understand urinary tract infection in older populations and kind of the pros, kind of how you make that diagnosis. That's important background. Exactly. One thing I want to build on that while I have the microphone is we haven't even really talked about how underdiagnosed this is to the extent. So if this is, with our current knowledge of the prevalence of dementia and the related costs and burdens of the caregivers, et cetera, and all the issues, there's some information that maybe up to 30 to 50% of people are underdiagnosed. And then, albeit might be earlier stages, but this problem could be even bigger than we really realize.
Yeah, I think, the key here is being able to recognize a change in condition. And that's what we need to have the caregiver educated about. Once we recognize a change in condition and recognizing that early, we have interventions that we can bring to bear. Our case managers working with a caregiver could have the patient seen by a PCB. It may be just changing medications. Maybe it's sending someone to the home, referring to a specialist. There are things we can do. But the problem in a dementia patient, in my mind, is the delay in knowing that there's been a change in condition and what that might mean.
Yeah, and maybe I'll just chime in here. And obviously, at Suresti, we have this technology enablement capability to get the caregiver to identify and raise their hand when they see a changing condition. So given the importance of that and the, 48 to 72 hours sort of time to take action, right? That seems like it could be quite valuable to sort of say there's a signal. And as you said, Bart, there are, once you get the signal, you know what to do about it. It's learning about the signal that is sort of the thing that doesn't easily exist today.
Yeah, otherwise, patients end up in the ER. And if you're in the ER, you have a very high chance of being admitted. And that's where the costs are. And frankly, that's the worst place for a dementia patient to be, because when they come out of the hospital, things are even worse.
Yeah. So, we've covered, I'm just going to rephrase here, right? So we've said dementia, more expensive than you think. Costs are driven by hospitalization, right? The key to hospitalizations is likely the detection of a changing condition in the home. So let's suppose somebody in the audience says, I buy all that. What are the considerations if you were going to set up a dementia care program? Like, what would be the things that if you were on the health plan side or the provider side that you'd want to think through? Because what we're really suggesting here is that this condition warrants its own specialized clinical program, which is not conventionally what people think about. So, with your experience in plans and providers, how do you do this? And Cheryl, maybe you'll kick us off here, thinking about, like, if you were in a plan and thinking about this, like, what would you want to learn? What would you want, what risks would you want to take off the table?
Well, it starts with knowing who these individuals are, which is fairly easy for us to say. If you are a plan and you have 100,000 members, I dare say you do not have a registry that says I have these 420 people with dementia-related illnesses. So case finding becomes very problematic. And often the case finding is buried in the utilization management review for the person who is continuously missing appointments or continuously showing up in the emergency room. So case finding is challenge number one. And there are some strategies to do that without a doubt. The second in setting up such a program is, one, you need to have individuals. We talked a little bit about the skill in recognizing dementia, but also the skill in helping to support families where much of the issues that are driving are behavior related. And that even came up in one of the chat comments. It's often the escalation in behavior issues that trigger ER visits by the family. So being able to mitigate that is critical. The third is, and I talked about the poly-management syndrome, we don't want this just rotating around people. It needs to be integrated with the person and their care, informal family care team, as well as their primary care team, so that solutions are aligned and the conversations are straightforward and managed. It needs to be anticipatory. And as John, and I'll end with this, I started an Alzheimer's management program over 20 years ago. So this isn't new news. But what we did is we had great binders of resources and we sent them to all the family members and they stayed on the shelves. Because at the time of crisis at 3 o'clock in the morning is not when you go, oh, I have a binder, let me go look through it. So you need just-in-time information. You need a two-way street for communication and escalation when the family and care team is saying, I don't know what to do next. Those are the elements that will then demonstrate to what the plans are looking for is decreased cost in care. Yeah, no kidding. But also member retention, member and family satisfaction. Those things are also key. And we can get into some of the STARS quality measurement that will also be improved once you start aligning care with what the individual needs in the setting that they are.
So what about a make or buy decision, John? So you've been CMO of a health plan. You probably went through this all the time. Are we going to do this ourselves? Are we going to partner? when it comes to a clinical programs for dementia, what are some of the ways to think about make versus buy?
Yeah, and I think that's a key question for any population health team. One of the things that, to add to what Cheryl said, that expertise that you need is how do you enroll these people? Because it's a different process than you would say on a complex care management program. It's you need a different person and a different outreach strategy. So once you find them, as Cheryl talked about, how you enroll them in the program, because it doesn't do any good to have the program if nobody says yes or you can't get a hold of them. So that expertise is really important. And then, when I think about, so in our organizations, we would start with the complex care program, which got rid of the poly management piece that Cheryl said, and brought expertise around social determinants, et cetera, to the table. But sometimes there's such a frame shift in a situation where you really have to change your approach enough that a separate program is important. One example of that, I think, is palliative care and end-of-life programs. There's just enough of a frame shift in thinking about what to do things differently. And I think in this case, dementia is also one of those. And anytime I was sitting in the chief medical officer chair, I had to do something special that I wasn't really good at. I would look into the market and see what my choices were. And frankly, and I told the people that I was talking to that I want to learn. I'm gonna outsource this because I can get it going faster, quicker. Maybe not cheaper initially, but it's an investment that I can get kickstarted really fast. I start getting the returns much faster if I try to build it myself. And then I might take it over later. I mean, I might, if it's really critical, if it's really that big of a thing, then I could insource that at some point. But that would be the typical strategy.
And then, Bart, from the provider side, right? If you're in an accountable care organization, MSSP or REACH, your calculus is a little bit different, right? Maybe it's additive. So think from your chair as leading a big accountable care organization, how would you think about thinking about bringing in or building a dementia care program?
Yeah, the first consideration is that as a medical group, we have a lot less money than a health plan to add programs to what we're already doing. And so we're very thoughtful before we would add a program. We'd have to really understand the value that could be brought by adding a dementia program. And obviously, prior to these conversations, most people probably weren't aware of the potential opportunity because we're already doing, as I said, the standard diabetes, CHF, COPD. So why would I add a dementia program? Show me the patients, show me the data, show me the information. And okay, now I understand, but I still have to pay for this. And can I justify that through the return on that investment through lower cost? Having the guide model, I think, is very helpful for groups like ours to see this differently, that, okay, there really is something that CMS has identified here that's worth focusing on. But build or buy, building is a lot harder when you're starting from scratch. And so if I had someone who could help me jumpstart this program, once I was convinced of the value, I'm all in there.
Okay. I want to bring up my one slide on guide and just spend one more moment on this. So that's the slide here. And then I just want to have a conversation about, the guide model. So again, for those in the audience who may be not familiar with the guide model, it's a new CMS model, CMMI model for comprehensive dementia care. It's addressing the problems of, fragmented, poor management of coexisting conditions, fragmented care and poor management of coexisting conditions. 8-year model. CMS will pay a capitation, right, to people who are participants in the guide model. So for the first time, you've got CMS paying for caregiver support, respite for the caregiver and so forth, which I think is super exciting. And it's built on sort of, I think, almost a decade's worth of research to identify best practices, many of which were developed by, leading academic medical centers focused on this problem. So I'm going to stop the share here. So I'd like to now just sort of ask the question, given that the guide model exists, right? How does, first of all, John, maybe I can start with you since you're kind of representing everybody. I mean, Cheryl, you're a geriatrician too, but what is your sense of the guide model and its ability to impact care?
Probably the first thing I like about it is if you think about the old insurance models, insurance is designed to insure against a rare event. When you have admits per thousand of 1,000 per year or something like that, 1,000 per thousand per year, that's a high frequency rate. So the insurance model doesn't work. So what I like best about this is you're spending money ahead of time, investing in the preventative care, caregiver respite, all the things that we've talked about in terms of a model of care. That upfront investment is paid off and just makes a ton of sense to me. And it allows for the first time, I was in the VA, but you could not replicate that model in a fee-for-service environment. So now we're able to do that in fee-for-service. The second thing I like is the clinical model. So I think they've got a really good handle because there's been enough people, Cheryl and others, working on Alzheimer's and related dementia care for a long time. There's enough expertise to say, we generally know exactly what or not exactly, we generally know what the model should look like, and I have these elements, and I really think they've done that well. I think it's also going to bring much more awareness to the field around the underdiagnosis and the opportunity to manage people. And then, we're going to learn a lot. And one of the two learnings I think we're going to have is not just, what's the best care model, maybe the tweaks in there, but more importantly, what is the cost savings potential over the long term? And for me, I love respite as a caregiver benefit. I don't know how effective it is or the right elements. What's the right way to do respite? So I think that's an important question. So I see all these things as being very positive.
So the guide model is not, MA is not really able to participate. So I want to ask Cheryl in a moment about this. But before we do this, Bart, it's obviously focused on traditional Medicare, the types of patients that can be aligned with an ACO. So from an ACO perspective, how do you think about the guide model?
Well, I'm very positive about the guide model. First and foremost, it's shining a bright light on dementia. And that's something that's new. If CMMI has focused on dementia, we ought to be thinking about dementia differently. And then whenever we're working in an ACO model, we always have to think about what we're going to be spending to impact the care versus what we're going to be saving in the long run. Savings have to exceed the cost of intervention. And I think that with what we've heard today, we certainly can feel very comfortable that if we can find someone to help us with dementia care in the ways that we've discussed, particularly with a caregiver, that can bring great savings, certainly in excess of what it would cost us to enter such a program.
Okay, so Cheryl, MA plans are not eligible, but they're unlikely to ignore the fact that CMS thinks dementia is important. So how do you think health plans are going to think about the guide model?
Well, I want to clarify some things. There's nothing that prohibits MA plans from doing this already. They didn't need the CMS regulation guide model because CMS will say, look, guys, you're already paid through this with your RAF scores and your risk adjustment based on disease states. Now, MA plans can argue back and forth on that, but let's put that aside. When I say that MA plans are not eligible, they could have done this yesterday. They didn't need permission from CMS, but the guide model gives a structure. So I'm going to think about it from a health plan. First of all, market share. This is a growing huge number. We already know the impact of the growth in individuals over 65 and the related growth of individuals with dementia is critical. So if you are an MA plan, are you going to ignore in some populations up to 20 to 30% of individuals over 75 having a dementing illness and just not take care of them? Are you going to ignore them and then pay the subsequent costs that are kind of invisible to you, but through the churn that we've talked about? So I think what MA plans can think about is what are the elements of guide that matter the most and that they can start to implement right away. So if you have care management, how do you create a care management model that works for people with dementia? How do you create a bi-directional approach so you're not just having a monthly phone call or a once a year home visit, but you're actually part of the support team for the family with dementia? I think there is huge opportunity for MA plans to step back and say, I'm already taking care of these individuals. I'm already paying for them, and I'm paying a lot that I don't even appreciate. And I can do so much better if I just rethink about how a care team can work. And then lastly, I have been back in my SNP Alliance days. my kind of standard platform was, we can't think of the payer health plan and provider, physician and other provider communities as just a payment relationship. It is a dyad, it is a partnership and it's frankly a triad with the person and the family care team in the center. But MA plans can use the guide model now to think about, how do I partner better with the physician groups who are taking care of the patients that are my members. So I see these as significant opportunities to really transform care, and MA plans can drive it.
This is awesome.
And
Thank
I'm
you.
ridiculously optimistic. I'll just put it.
This is a terrific discussion. I'd like to now do the following. I'd like to take a couple of minutes and summarize what I heard, and then we'll turn to questions from the audience. Right. So at a high level, right, I've got some of this written down, so if I'm looking down, I'm actually reading. But the real costs of dementia are largely invisible, right? We talked about this. There's a masking of symptoms, there's the way claims data is pulled, and there's some other reasons. In the fee-for-service set that we looked at, dementia was the second most expensive condition in Medicare, right? So this becomes apparent if you can aggregate all the costs of people with dementia sort of into one bucket and think of managing them in a dedicated program. We learned about the CMS guide model. We talked about this twice, which is in part aimed at reducing costs in the face of an aging population. And I think CMS, as Bart said, is sending a clear signal, like dementia is a national priority, you should pay attention. There is a multiplier effect we talked about that's connected to the masking, which is driven by the patient's inability to self-manage. And the costs of dementia people are largely driven by unmanaged chronic conditions, infections, and falls, and it's not so much only the dementia. So again, we're sort of advocating or suggesting that you should consider managing these folks in a specialized clinical program. A program has to include the family caregiver, and ideally, you know, a program that leverages a family caregiver to kind of detect a changing condition. We talked about that some of these programs exist today. We learned that hospitalizations are the key driver of hospitalizations, and that, again, detecting a changing condition is super important. The family caregiver, as John said, is motivated. Sometimes they're 24/7, and they're in the best position to determine if there's a change that falls outside of a baseline, right? Early on, we talked about Suresti's tablet-based approach to dementia care, where the caregiver is engaged and we can detect a changing condition in the home. Bart helped us sort of think about the considerations of an ACO, Cheryl from the health plan perspective, and we sort of said that, hey, cost savings matter, right? There's all kinds of things you can impact stars and CAP scores and so forth. The implementation has to be easy. There has to be a model, right? The cost savings has to be reconciled against the expenditure of the program. And I think that's important to think about as you partner. And then we just started to unpack at the end sort of how the guide model can further increase shared savings in dementia care, whether you're an ACO or a plan. And I love your enthusiasm, Cheryl, for, you know, how health plans who really could have been doing this all along might now sort of get remotivated to say, let me take a look, let me confirm that it's really so expensive, and then, you know, do a lot to improve care for their loved ones. So we're actually 11 minutes from time. So I'm actually super pleased. We've got some time for questions. Nicole, are there any questions that you'd like to read out that we should address as a group?
We've got some great questions, so I'm just going to jump right in. The first one being, how do you clearly attribute cost savings within the dementia population, given the multiple comorbidities and nature of the Alzheimer's related dementia disease course?
So one of you want to jump on it? If not, I'm happy to add some color.
Well, I'll start with, there have been several studies that look at diagnostic groupings with individuals that have dementia and with individuals that don't have dementia. And for the same diagnoses, the costs, the Alzheimer's Association, more than 10 years ago, did a great study on congestive heart failure, looking at dementia, non-dementia, and the costs were roughly a third higher for individuals with dementia. So there is data out there, but it's usually buried under disease specific. I think my one caution to health plans looking at an ROI for setting up a dementia care plan is these are not going to be quarterly returns. If I start one in February, I'm not going to necessarily start saving money in May. It's going to take cycles, and health plans are not really patient with cycles, but it may take a year or two in a large enough population to start seeing cost savings. So that's just one caveat there for
I think
caution.
you'll see cost savings, but it will increase over time. So I don't think we
True,
would.
but there's also upfront costs in establishing the program. So the break-even piece may take a
Sure.
little bit longer. But you're right, Barb.
I'm going to ask John this is, I think, a really important question. One of the inherent, I think, realities that make attribution easier is that these patients are not captured largely in other programs. So John, maybe you can talk to the overlap, right, of dementia and other programs if you had a dementia program. And that would obviously make attribution easier because you don't have to deal people in other programs out of the deck.
Yeah, I mean, I think what you're alluding to is in a typical complex care program, you don't find people with dementia enrolled, either because they haven't been targeted or because they are sometimes filtered out, or maybe more importantly, it's just difficult you can't call them directly and say, hey, we have a program for you. You have to go through the caregiver. So it does get more challenging. And so you know, in the health plans that I've known with dementia programs, that there's very little overlap between a dementia specific program and then the rest of their programs, regardless what the underlying diseases are, because they're just not in your typical complex care program. Yeah. So I do think, given the unique nature of the combination of dementia with other conditions, as Cheryl was alluding to, I do think it's worth a special look, and the attribution would be, you know, all the costs of people with dementia is in any of those top 10 fields, if you go down 10. And that would really lend itself to a special intervention, I think, compared to what a typical program might have.
Nicole, any other questions?
Yes, many. So I'm going to keep on going. If PCPs don't bear the large majority of the costs of dementia, for example, ER visits, would PCPs be incentivized to refer patients with dementia out to dementia-focused specialty providers and vendors?
I'll start that. Well, I think that PCPs who have patients with dementia are looking for help, period. They really don't want to have the dementia patient coming into their office on a regular basis, because while they know how to identify dementia, they don't really know what to do with dementia. And so having programs like we're talking about to intervene in the care of a dementia patient, to support the PCP in their care, having care managers and the caregivers working together are very, very helpful to the PCP. And then we can call on the PCP when we need it to do something specific to help care for that patient or to refer them to the appropriate specialist.
Yeah, it's exhausting for offices, for the office staff, for the PCP and the team. And these visits are often 30, 40 minutes long when there's 15 minutes on the book. So now your entire office day is backed up. And as Bart identified, they don't know what to do with them. And that goes the same thing for the special. We're talking a lot about primary care physicians, but if you're a cardiologist, if you're a general surgeon, if you, any of the specialty areas, and you're focusing on a problem, not having resources in order to support the individual with dementia becomes hugely problematic. So it's more than just the cost savings to the primary care or physician group. There's an abundance of value add to moving the practice, improving care, improving the stress of the staff, keeping schedules on time. There's just so many impacts.
Yeah.
I would just add that I think one of the barriers of advancing the care on this topic is the fact that primary care physicians aren't engaged in the costs, downstream costs of emergency room or hospitalization. I'm a big fan of participating in advanced care payment models. Primary care is central to those payment models in terms of reducing hospitalizations. If I've got a patient I've had for 25 years and now he or she develops dementia, I'm going to be reluctant to say goodbye, just go to the neurologist. So I'd be much rather aligning incentives as a system across the primary care docs, that we're all in this together and we all own a piece of this. It doesn't have to be full risk, but I do think we should be part of that solution as a primary care doc.
John, I agree with you completely. In the Medicare Advantage programs where we are taking risk, the primary care are very much engaged because they do understand the concept of risk and reward for them. And in the ACOs, it's that way as well. A little harder because the ACOs are, frankly, mostly immature in terms of experience in this, and the primary cares have to learn that there is benefit to them, not only in the care and in their offices, but economically. And that's very important. Our primary care did much better in risk models, and they recognized that, understood that, but they didn't believe that from day one. So you've got to demonstrate it.
Right. Nicole, I think we have time for maybe one more question.
Yes, I've got another one ready to go. Can you go deeper into the key elements of digital health programs Suresti is implementing, and are insurers covering these services?
Okay, so I think this one is directed at me. We largely have a tech-enabled service that, supports members with dementia. We engage the caregivers. As we talked about, the enrollment piece is critical. So we provide a turnkey solution for doing this. And then we essentially guarantee a return on investment for a simple fee. Right. So we understand the financial calculus to an organization, and we have tried to build a business model that makes this very low risk for an organization. So, from the caregiver's perspective, this is a caregiver support program, right? We can't call and say, hey, we know your loved one has dementia, are you interested? None of that's allowed, right? So navigating HIPAA and just sort of understanding, how do you connect with a family is something that we have spent the last 7 or 8 years really getting good at. But based on the outcomes that we get and the testimonials, we are having a huge impact. And I think the guide model will just strengthen our ability to provide game-changing support for families, right? In an economic model that makes it free to the family, but delivers a reason for a payer provider to engage with us.
Dirk, do you want to talk about the technology at all? I think that was part of the question.
Yeah, so part of what we do, thank you, John. Part of what we do is we send a tablet to the caregiver. On the tablet, there's a lot of personalized education. We prioritize this based on risk models we run in claims data and information we learn about the caregiver. So there's a highly personalized tablet with personalized education. There's a care navigator, and then there's an opportunity for the caregiver to report a changing condition. And we get about 2 of those a week, sometimes as many as 2.5 check-ins by the caregiver going on for many months saying, here's what I observe. And we triage that information and work with partners to then say how we're going to address the changing condition. So that's the fundamental model. It really gets at a detection of a changing condition by a family caregiver, typically a spouse or an adult child. And in Medicare, at least, we found half the caregivers can be spouses. So they're not necessarily proficient with using a smartphone. So we are at 11:59. So again, I can't thank the panelists enough for this engaging conversation. This will obviously be recorded, available for posterity forever. And so again, thank you. And I'm going to turn this back over to Nicole for any closing remarks from the HLTH organization.
Thank you to Suresti Health and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, October 20th through 23rd for Health 2024.